So my name is Dr. Wahome Karanja. I'm a consultant ear, nose and throat, head and neck surgeon. I'm working in Nairobi in the Prodigy ENT and Hearing Clinic located in KMA Center in Upper Hill. On behalf of the Kenya Paediatric Association and the Pfizer Educational Grant, I am pleased to be able to offer this online CME on common problems, different views, the pediatrician and the ENT approach. So in terms of ground rules, ENTs and take two stands. One is that we are minimalist, and two, we really appreciate the teamwork approach with our fellow colleagues, the pediatricians. So I'll begin with the nose. And in front of you, you can see a picture of a child who is having nose bleeding or epistaxis. Now, epistaxis is a common occurrence in children, regardless of the age group, maybe unilateral or bilateral, and therefore a history is important. In majority of this age group, we are dealing with an anterior bleed from the Little's area, which is a convergence at the anterior nasal septum of the generally valveless blood vessels. If you have a unilateral and epistaxis, you are likely to be dealing with a localized problem, and the commonest cause for epistaxis in children is actually nose picking. Others include upper respiratory infections or inflammations of whatever cause, and of course there are more sinister causes which include bleeding diathesis and problems with coagulation. A good history and physical examination is necessary because epistaxis can actually be fatal, and a good understanding of primary first aid in terms of nose pinching and leaning back, maybe cold compresses with ice, is useful for the clinicians to be able to teach. And I think these are two areas that we generally agree on in terms of both ENT and pediatrics. So once you have stemmed bleeding from first aid, then in terms of follow-up, what should you advise these children or their parents? One is to avoid blowing their nose, and therefore you just wipe gently, because blowing the nose dislodges clots and therefore causes worse bleeding. And avoid hot drinks because of vasodilation that can lead to further bleeding. Antibiotic creams can be applied in the area of epistaxis for about a week. And when you have severe epistaxis, then that may be a reason to admit and therefore carry out certain tests, and also of course maybe some invasive maneuvers to be able to stem the bleeding. Of course, a full blood count would be warranted in excessive bleeding, and we can be able to do silver nitrate cautery even in an outpatient setup, and you can be able to pack or use electrocautery. If it is very severe coming from the SPA, then ligation may be done or embolization of the external carotid artery intraoperatively. What do you need for cautery? And this is something that is good and important for all of us to have. You need a good light source, preferably one that is on the headlight, which allows you to have a two-handed approach. You need a nasal speculum or a large aural speculum. Lignocaine spray or xylocaine spray is good, especially with adrenaline, that can help to both vasoconstrict and cause anesthesia. Cotton wool and cautery sticks or electrocautery, and liquid paraffin, which helps to moisturize the area. We want to speak a little bit about rhinosinusitis, because this is definitely one of the most common problems that present children with. And rhinosinusitis has certain causes. One may be allergic, viral, or infective, which is bacterial, fungal, and also autoimmune. In terms of definition, rhinosinusitis may be acute, which means symptoms persist less than 12 weeks, or chronic for more than 12 weeks. Most studies show that 15% of the population are affected by rhinosinusitis, and there's a lot of working days lost per year in the UK and in the world at large from sinusitis. And generally the symptoms are, you know what, my cold won't go away, and this is persistent without improvement for more than 10 to 14 days, sometimes worsening after 5 days. And we divide the symptoms into major and minor. Major being nasal congestion or obstruction, purulent nasal discharge, loss of smell, or facial pain, ear pain, or fullness. And in terms of minor, you may have tenderness over the sinus area, fever, headache, halitosis, fatigue or lethargy, and postnasal drip. What you need to exclude on the physical examination from the history is a periorbital swelling or extraocular muscle dysfunction, because this might imply a complication, orbital complication of sinusitis, which is more common in children. You want to exclude foreign bodies, especially if you are talking about a unilateral nasal discharge, concomitant otitis media, which is common in children with ear pain, central nervous system complications like meningitis or abscesses, and of course polypoid changes or deviated septum, which is a bit rare in children. And what you expect to see on examination is swelling or erythema of the nasal mucosa, mucopurulent secretions, or tenderness over the sinuses. And you want to consider emergency admission to hospital if the symptoms are accompanied by a systemic illness, a swelling or cellulitis on the face, signs of central nervous system involvement or orbital involvement. And of course, it is good to consider ENT referral if you have persistent symptoms that are not going away with treatment, especially those that might suggest a sinonasal tumor, for example, bleeding, an untender facial pain, facial swelling, and unilateral polyps. And of course, a routine referral if you have more than 3 to 4 episodes per year, lasting more than 10 days, no symptoms between episodes. Is a CT scan necessary to make a diagnosis of rhinosinusitis? Considerably not, and the reason being, sinusitis is actually a clinical diagnosis based on symptoms and physical findings. So if you have 2 or more major symptoms, or if you have more than 3 minor with 1 major symptom, then you definitely have a diagnosis of sinusitis. Where do we require to have a CT scan in patients? Generally, as a rule, if you have persistent or chronic rhinosinusitis and you are considering surgical intervention, in this case you would consider having a CT scan, because it would act as a guide to very necessary structures, and in this case the orbit or the brain, to be areas of avoidance when you're going in for endoscopic sinus surgery. Having said that, especially in this part of the world where we don't have a lot of cystic fibrosis or ciliary dysfunction disorders, endoscopic sinus surgery in children is really not the norm, and therefore as a rule I would say, you know what, avoid asking for CT scans, which would otherwise just give undue irradiation to these children. How do you manage acute rhinosinusitis? Majority being viral, of course, symptomatic management is considerable. But if you have bacterial, which usually has more severe or prolonged symptoms, then you want to give a course of antibiotics. The commonest microorganisms, of course, tend to be strep pneumonia, H. influenza, and Moraxella catarrhalis, and therefore first-line treatment would be amoxicillin, and second line being amoxicillin, clavulinic acid, or azithromycin for those who have penicillin allergies. Ideally, what is most important in terms of treatment for sinusitis is we need to give treatment for a period not less than 10 days, preferably 14 days, to have effective and complete management. And nasal foreign bodies, these are commonest in the age group between 1 to 4. And one of the problems they present is a potential risk to the airway. And of course, you want to suspect this, especially if you have a unilateral symptom of blockage with a foul-smelling discharge. Now, the rule is, unless it's simple to get at, or the child is very compliant, do not attempt to remove, unless, of course, you are able to restrain the child and you have the necessary instruments, which could include hooks or crocodile forceps within the office environment, and of course adequate lighting to be able to remove them, because the risk is pushing them further in or actually complicating through upper airway obstruction. Nasal fractures are rare, but in the older age group, especially because of spots, more common in boys, and it's best to view from above. And of course they would present with a history of trauma with nasal bleeding, and it is necessary to exclude a septal hematoma, because that requires immediate drainage, and if you do not drain, then of course you have a risk for developing a septal abscess, which will break down the nasal septum and therefore cause a subtle nasal deformity. As a rule, we want the nasal fractures to be dealt with at least within the first 14 days after the injury, when tissues are still malleable, and of course when edema has reduced significantly. And majority of times we do this through a closed reduction intraoperatively. We want to talk a little bit about the adenoids, of course, which is the commonest problem that we deal with in children in terms of upper airway obstruction. And this is basically part of the tissue which is called the Valdea's ring, and adenoids specifically found in the postnasal space, with a peak age of development and therefore symptoms between the age of 4 to 5 years. But of course we see children with earlier symptoms of nasal obstruction presenting. What are the current indications? And we borrow from our setup from the American Academy, which says, you know what, if you have 4 or more episodes of recurrent purulent rhinorrhea in the prior 12 months in an infant, or if you have persisting symptoms of adenoiditis after 2 courses of antibiotic therapy, or you have sleep disturbance with nasal airway obstruction persisting at least 3 months. The other indications include hyponasal or hypernasal speech, otitis media with effusion for more than 3 months or a second set of grommet tubes, dental malocclusion or orofacial growth disturbance documented by an orthodontist, cardiopulmonary complications, and of course we should not wait for this, including copulmonale, pulmonary hypertension, right ventricular hypertrophy associated with upper airway obstruction, and otitis media with effusion in an age group above 4. These are indications for adenoid surgery. Now, it is controversial whether to include adenoidectomy with myringotomy and grommet insertion at the same time, but by and large, as a rule, we would prefer to get rid of the adenoids and allow re-establishment of proper flow through the eustachian tube. And in case of persistence of otitis media, then we can consider myringotomy and grommets. So in terms of the throat, of course, sore throat commonly would happen from rhinovirus or viral infections. Of course, there is group A beta hemolytic strep throat, which carries the risk of other non-suppurative complications, herpes simplex virus, and of course Epstein-Barr virus. The other non-infectious causes of sore throat include physical irritation, hay fever, Stevens-Johnson syndrome, Kawasaki disease, or oral mucositis secondary to chemo or radiotherapy. In terms of complications of strep pharyngitis, these are rare, and the suppurative ones include otitis media, acute sinusitis, peritonsillar cellulitis, peritonsillar abscess or quinsy, pharyngeal abscess, and retropharyngeal abscess, more common in children. And of course, in terms of treatment, bacterial tonsillitis is something we all clinicians would be able to treat, but in terms of a peritonsillar abscess, this requires drainage, and in the case of a second episode of a peritonsillar abscess, you need to consider a tonsillectomy. The non-suppurative complications we are all aware of include rheumatic fever or post-strep glomerulonephritis. When do we need to refer tonsillitis or sore throat? One is to be able to admit if you're dealing with stridor or respiratory difficulty, especially if you're dealing with a complication like excuse me, if you're dealing with the complications of trismus, drooling, or dysphagia. Again, if you are having dehydration or unable to take in fluids, this requires, of course, fluid resuscitation. And if you're having severe suppurative complications, for example, abnormal swelling or suspected abscesses that require drainage. Again, if you're dealing with a child who is systemically unwell and at risk of immunosuppression, suspected Kawasaki disease, or a profoundly unwell child in an unknown case. What are the indications for tonsillectomy for recurrent acute sore throat? One, and this would require tonsillectomy by definition as something that is documented by a clinician to be fever and painful swallowing, and temperatures probably above 38 degrees centigrade, and mucopurulent discharge over the palatine tonsils. So again, as an indication, if you're having sore throats that are due to acute tonsillitis, episodes of sore throat that are disabling and preventing normal functioning, which would be 7 or more well-documented, clinically significant, and adequately treated sore throats in the preceding year, or 5 or more such episodes in each of the preceding 2 years, or 3 or more such episodes in each of the preceding 3 years. Vertigo. Now, vertigo is not very common in children, and many times would be as a result of a systemic disease. For example, if you have an upper respiratory infection with a viral of viral origin. Vertigo generally is a symptom that refers to a perception of spinning or rotation of the person, their surroundings, in the absence of physical movement. In terms of peripheral vertigo, which usually arises from labyrinthine causes, you may be dealing with either benign paroxysmal positional vertigo, vestibular neuronitis, which is more common in children, or Meniere's disease. Central vertigos, which are usually of cerebellar origin, are commonly resulting from migraine in young adolescents or adults, and uncommonly because of stroke or other symptoms which are more common in the elderly. Tinnitus is an unwanted perception of sound within the head in the absence of sound from the external environment. It can be described as a ringing, a hissing, buzzing, roaring, or humming sound. And they may be subjective or objective. Commonly with children, they result from an abnormal exposure to loud sounds, especially if it is unilateral, or as a result of medications that might be ototoxic. In terms of foreign bodies of the throat, you mainly get them in the areas of narrowing, which would be the throat or the esophagus. And if you have complete dysphagia of acute onset, then there's a high chance of a foreign body obstruction. If you have a delayed onset of foreign body sensation after eating and mild symptoms, it could simply be an abrasion, and the symptoms tend to go away in about 48 hours. And of course, you need to refer if this does not resolve. There are certain home remedies that have been prescribed, but these need to be done with care. For example, giving esophageal food bolus, like taking a banana, taking a Coke or pineapple juice, and so on, that can be useful. Facial nerve, or the seventh nerve palsy, is lower motor, especially lower motor neuron, which involves the forehead, is a rare occurrence, and it can also affect taste to the anterior 2/3 of the tongue. Possible causes might be trauma, where you have facial lacerations, or blunt trauma, or what can be found in newborn paralysis. It could be neoplastic, which is rarer in children, infectious, because, for example, herpes zoster, or idiopathic, in this case, Bell's palsy. So we need to do a full head and neck examination when we have when we are faced with a facial nerve palsy, and if it's Ramsay Hunt, we can give a cyclovir for a certain duration of time. Steroids are usually helpful, and of course, eye taping at night with artificial tears are useful to protect and close the eye. And of course, we need to refer if there is a hearing loss, and of course, if there are ophthalmic complications. Again, prognosis depends on cause, but by and large, they tend to recover well and fully with physiotherapy. Salivary gland problems are also things that we face with commonly sialolithiasis or inflammation or sialoadenitis. It may be acute, chronic, or recurrent, and tumors are rare in the pediatric age group. In terms of inspection, we need to inspect the enlarged glands and all others. If it is tender, then we are more likely dealing with the sialolithiasis. If it's non-tender, possibly tumor. And when you have more than one gland affected, it may be autoimmune or viral. For example, in mumps, which is the common cause of parotid enlargement in children. And of course, it's important to test the facial nerve. It's important to inspect the oral cavity, both manually and bimanually, and you might be able to palpate a stone or express parts from a duct in case of infection. In terms of the ear, of course, we know that the ear is divided into three parts, which is the outer ear, the middle ear, and the inner ear, with a separation of the round and oval window, and of course the tympanic membrane. What is most important is for us to be able to do a proper otologic examination, either with a video otoscope or a traditional otoscope that can be able to delineate the landmarks within the ears, which would be the handle of the malleus, the cone of light, and of course the pars tensa and the pars flaccida. External otitis is an inflammatory disorder of the skin lining the external auditory canal. It may be acute, it may be chronic, and may be part of a generalized skin disorder. And commonly the pathogens are either bacterial or even fungal. But when you have a fungal otitis, you tend to have more intense itchiness, and treatment usually is a topical antibiotic or steroid. Again, otitis externa may extend to the pre or postauricular area, which would require manipulation in terms of treatment and probably systemic antibiotics. This would be worsened in somebody who is immunosuppressed, for example, diabetics or HIV infection, and of course sometimes can be a pointer of malignancy. Now, swimmer's ear is one of the most common otitis externa variants that we get, and commonly you get a history of having traveled to the coast or having indulged in some form of swimming, and you have intense itchiness, pain and irritation, and probably oral fullness or blockage in a child, many times unilaterally. So ideally, with a good physical examination, you can determine swelling of the external ear canal that would may require treatment, may require oral wicking, and of course systemic analgesia or anti-inflammatories and topical antibiotics. Acute otitis media is common in children. In fact, it's probably the most common cause for pediatric visits to an outpatient department, where you present with otalgia and oral discharge. The child usually is unwell with pyrexia and very high temperatures, and on examination you find a bulging, red and very edematous tympanic membrane. Commonly these are caused by either streptococcus or Haemophilus influenza, and treatment is usually amoxicillin or amoxicillin clavulinic acid for 5 to 7 days. Unfortunately, in delayed treatment or not treatment at all, you may develop complications which may be mastoiditis, chronic otitis media, which basically implies a perforation, or intracranial complications. Chronic suppurative otitis media is something that we certainly encounter frequently, and the usual history would be presentation of recurrent ear discharge, hearing loss, perforation of the tympanic membrane, which commonly is central, and there may or may not be a presence of cholesteatoma, of course, which makes this a dangerous perforation. Marginal or attic perforations tend to be more dangerous. They may be related to cholesteatoma, and they have little discharge which is offensive, and you might be having bleeding or granulations that are associated. In terms of complications, chronic suppurative otitis media, you may have vestibular complications, you may have facial palsy or intracranial complications. How do you manage chronic otitis media? Again, this is where you probably need some level of lighting and oral wicking. The most important preamble to treatment, of course, is dry mopping with cotton wool and not your cotton bud, suction clearance, and therefore it helps to have suction. Thereafter, installation of ear drops, and rarely do you require systemic antibiotics. Rarely do you need a surgical therapy in the immediate diagnostic period, except when you're considering myringoplasty or tympanoplasty. And of course, you may require to have a mastoidectomy when you talk about mastoid involvement. Glue ear is common in children, which many times might be discovered either by a parent or a teacher, and in children who may be having recurrent ear infection. Sometimes you may have children presenting with unsteadiness or falling over, and sometimes effusions persist for weeks after acute otitis media. But you know what? Fortunately, 80% of otitis media with effusion tend to clear within 8 weeks' time, and that's the reason why we are moving away from instinctively recommending myringotomy and grommet insertion, as opposed to purely adenoidectomy in coexisting adenoid enlargement in these children. So in terms of signs of otitis media with effusion, when you look through on otoscopy, you'll find a dull or a retracted tympanic membrane. You might be fortunate to find an air fluid level, and of course conductive hearing loss. And this is where we insist that no ear examination is complete without a tuning fork examination that conducts both the Weber and the Rein's test that proves evidence of a conductive hearing loss, especially in the children who are cooperative. Now here I'll probably speak a little bit about hearing testing in children. In Kenya, we do not give a routine hearing testing in children as one of the following birth. But I think time has come to be able to institute such measures through otoacoustic emissioning. And because the earlier we are able to diagnose hearing loss, the easier and the earlier we can be able to treat these children and give them a semblance of a high quality of life. Having said that, hearing testing is divided into two, where you have objective hearing testing, which is your standard pure tone audiometry, and this is usually conducted in children above the age of 5, in other words, who can be able to comply with instruction. Anyone below this developmental age of 5 needs to be subjected to subjective hearing tests, which include bearer or autoacoustic emissions that can be able to define the type and the level of hearing loss, so that we can be able to institute treatments. And the treatments would include anywhere from surgical treatment, from hearing aid amplification, or even cochlear implantation, which fortunately we are able to carry out today in our country. So if otitis media is persistent for 3 months or more, then would recommend ENT referral and perhaps myringotomy with grommet tube insertion. In terms of treatment, we want to treat otitis media with a fusion which has failed audiometry, in other words, confirmed conductive hearing loss, flat or type B tympanograms, and a history of more than 3 episodes in the last 6 months or 4 in 12 months. And the treatment is usually grommet insertion and or also management of enlarged adenoids. Syringing. Now, this is one of those controversial subjects. When do we need to syringe, or which ear needs syringing? Majority of times, fortunately, in children, you have who develop wax impaction, the wax tends to be soft. So one of the things we want to do first is to soften that wax, and there are a lot of medications which are even over the counter that can be able to soften wax. Without those, in the absence of those medications, olive oil, which is your traditional medicinal product, can be instilled regularly and be able to soften wax that can be able to be removed more easily. So one, you want to remove or syringe the ear which has an occlusive cerumen that is causing pain, causing hearing loss, or even causing tinnitus. Now, avoid syringing in cerumen that is non-occlusive, which can be removed through simple methods like installation of wax softeners, in an ear which has had previous surgery, because then you can lead to complications, in the only hearing ear, because you can jeopardize hearing in that ear, in a perforated tympanic membrane, because then you're going to introduce infection, and of course in keratosis obturans, rare in children, but this requires proper removal. And in the case of children, because of the pain thresholds, many times you want to clear this in an OR setting or under some form of sedation. So again, you have viral, you have a common pathology which is viral laryngitis, and this would suddenly be associated with aphonia, with a history of sore throat, and you may on examination find that you have edema or erythema of both vocal cords. Treatment for viral laryngitis tends to be just voice rest, antibiotics, or pain relief medications. Can help, especially with eucalyptus products. Hoarseness as a symptom may occur because of either a local or a systemic pathology, and is often seen as an early symptom of carcinoma, again much rarer in this pediatric age group. Vocal cord nodules are not very rare, and especially in the pediatric age group of between 5 and 15 years, especially in boys, and many times happens because of excessive or voice overuse, and treatment tends to be voice rest, a lot of rehydration with medications, and of course speech therapy. Rarely will you require to have microlaryngeal excision. Laryngitis resulting from gastroesophageal reflux is a new entity that is being increasingly recognized in children, which in which case, especially in those who are communicating, tend to complain about a foreign body sensation, globus or globus pharyngeus, hawking or constant throat clearing, and occasionally a nocturnal cough. And treatment tends to be, give anti-reflux medications and raise the end of the cot or the bed. Squamous papillomas have also been found, and especially respiratory papillomas. Unfortunately, the treatment for this is complete excision. Laser treatment tends to be less destructive, but they require treatment from time to time. Functional aphonia is also a condition that we find more in the female age group, in the pre-adolescent or adolescent age group, where you have somebody forcing a whisper, you may have a normal cough, or some level of what is called spastic dysphonia. And many times the treatment for this tends to be speech therapy. So with that, I hope we've been able to cover lots of the areas that we find ourselves coexisting in terms of management of both pediatric ENT and pediatric medical conditions. Thank you.